Hello everyone, welcome back. This is Professor Harkirat Bal, and today's topic is personality disorders. We are actually really going to get into different types of personality disorders in depth. So let's get started. All right, before we really get into detail of our topic today, let me ask you a few questions and see if you can answer that. Ask yourself, who exactly are you? What type of a personality do you have? What qualities do you present to others? How would your best friend describe you? How would your supervisor describe you? Do you think your supervisor is going to describe you the same way that your best friend would? Is your personality similar to one of your parents or siblings? And can you recall any event that you believe shaped your personality altogether? Is your personality the same the way it was, let's say, 5 years ago, 10 years ago? Or has anything happened in your life that changed who you are? Now, personality, in general, includes everything about a person, and that's why I'm asking these questions. We used to believe that, back in the days, people used to believe that the different personalities come from imbalance between blood, bile, and phlegm. Remember that was the deal back in the days about mental illness. They thought it was imbalance between bile, blood, and phlegm, and so forth. And but now we know that personalities are far more complex than that. We all have our own personality. That's what makes us very unique. Some people are shy and others are loud. Some people are polite and some others are rude. Some people are spontaneous in action and others are rather thoughtful. Some people are flexible, and some others are rigid, stubborn, and so forth. Now, all of these traits can be used to describe a person's personality. So take a look at it and see what type of personality you have before we really start assessing someone else's personality. All right. Well, the term personality comes from the Greek word persona, and persona simply means to wear some kind of a mask, a theatrical mask or false face. So take a look at this Batman, and he's wearing a mask, and he says, "I wear a mask, and that mask, it's not to hide who I am, but to create what I am." So that is his personality. Um, I always ask a silly question. Can you tell me when do you think this picture was taken? Do you think this picture was taken before COVID or after COVID? And clearly the answer is before COVID, because this is not how we are supposed to wear a mask. All right. So personality, in summary or definition, would be it is a sum of all emotional, cognitive, and behavioral attributes of an individual. So it's a very, very complex concept, if you will. All right. So what are some ideological factors? Well, as you can tell, there are going to be multiple. It's multifactorial disorder, if you will. And the first one, I always like to talk about environmental factor, and see if you have, when you are interviewing a child or adult, see if you can ask questions and trace any childhood trauma. Perhaps there was abuse, death in the family, any type of stress at that time. And most of the time, personality disorders comes from the fact that these clients have a maladaptive patterns of behavior that are going to cause, later on will cause a functional impairment in several settings. For example, either school, work, relationship, and so forth. There's also genetic factors, tends to run in the family. And number 3 is structural abnormalities, and more specifically in the brain, of course, decreased gray matter volume in the prefrontal cortex and also limbic system deregulation. And remember, prefrontal cortex is the part of the brain that is very complex, that makes complex decisions, and it's developed later on, and so forth. So the symptoms are present early on, but we usually do not diagnose a client with a personality disorder until after the age 18, with the exception of one disorder. We'll talk about that. It's antisocial personality disorder. But usually these disorders are diagnosed later on as an adult. But the symptoms are, you can trace these symptoms early on during the early childhood or adolescent. Okay, so number 4 is my favorite, theory, neurotransmitters dysfunction. We know that we have several neurotransmitters. For example, we have norepinephrine, we have dopamine, and so forth, right? We have serotonin. And I know some people talk about a decreased level of one and increased level of other. I think the best way to really describe these disorders are that you have imbalance. If you have increased level of norepinephrine, you have a decreased level. Now, just a decrease of something or increase of another neurotransmitter may not cause a significant symptom, but it's usually the imbalance between those two. Or I can say dysregulation of dopamine. And remember, dopamine is the one that gives us a pleasure, right? So these levels are low. Serotonin is responsible for your mood and so forth. And of course, norepinephrine is another, excitatory. It's going to influence your sympathetic, so you see some agitation and anxiety and so forth. So overall, it's a dysregulation of neurotransmitters. Now, these disorders are a predisposing factor for other psychiatric disorder. For example, you can have anxiety, impulse control, eating disorder, or substance use, and a risk of suicide. So very, very important to understand the concept of a personality disorder, because they do carry risk factors for other psychiatric issues. All right. Now, when we talk about personality, there's a concept of types of behaviors. And generally, we can divide the behavior in two broad categories, if you will. And the first one I have on the list is ego dystonic. Ego dystonic means you have a client whose behavior is going to be inconsistent with their personality. Whatever their personality is, their behavior doesn't match with the personality, and you can see that when you all of a sudden there's a change in behavior, right? You can say, but that's not him, that's not like her. These individuals are aware that they have a problem now, and they're very distressed about their symptoms. Those symptoms are bothering them, and they seek treatment. Now, example I will give you here is, let's say you have a client with OCD. OCD clients, they understand that they have issues. If you have a client who's gonna spend a lot of time taking a shower or washing their hands and so forth, they will talk about it. The second major category, broader category, is egocentric. Now, egocentric behavior is the behavior is consistent with their personality. These individuals do not seek treatment because they think there's nothing wrong with them, because these symptoms are not bothering them. There's no concern to this person. They're not in pain. They're not suffering. These individuals don't think they have a problem. Sometimes they think the problem is with you. So for example, let's say you have a client who's a bipolar, and at this time is manic. So when you're going through mania, or maybe even schizophrenia, when you are going through hallucination, psychotic features, they don't know that this is a problem. You know, they believe in that, right? If they knew that was a problem, they will stop, right? I mean, unfortunately, they don't know that that's a problem. And I'm sure you have heard from the patients now that, oh, you gave me incorrect diagnosis. I don't have schizophrenia. I don't have a bipolar. Those diagnoses are wrong, because they truly don't think that anything is wrong with them. They want to go back home if they are in a psych facility. And they actually think the problem is with you. They think, well, you don't like me. You're giving me wrong, incorrect medications. So by definition, unfortunately, most of the personality disorders are egocentric in nature, with the exception of maybe one we'll talk about, OCPD. Those individuals, they're aware of their stress, so that would be ego dystonic. So anytime when the client is aware, that would be ego dystonic behavior. And alloplastic behavior would be something where you have individual adapt by trying to alter the external environment rather than themselves. In other words, they are not going to change. They expect environment to be changed. So that's another one you can remember. But these are the two main broad types of behaviors, if you will. And see, and this becomes a problem later on. You'll see that we really don't have a good treatment plan for these patients. And to begin with, we know these patients are not going to come seek for treatment. And even if they do, there isn't any good treatment that we can offer. So these patients truly suffer most of the time for pretty much for all of their lifespan. All right, so take a look at this slide. This is a very, very important slide. My entire lecture is going to revolve around this slide now. So DSM talks about personality disorders in clusters. So you have three clusters altogether: cluster A, B, and C. Under each cluster, you have group of behaviors that pretty much share same kind of a feature, if you will. So it's a theme for that cluster. So cluster A, the theme is odd and eccentric behavior. Then you under that cluster, under that theme, odd and eccentric, you have three different types of personality disorders. Number one is a paranoid personality disorder. Number two is a schizoid personality disorder. And number three is a schizotypal personality disorder. And we are going to talk about them one at a time. Cluster B is the overall theme would be dramatic and emotional. And there are four personality disorder underneath. Number one is antisocial personality disorder. Number two is a borderline personality disorder, histrionic personality disorder, and narcissistic personality disorder. And cluster C, a common theme would be anxiety and fear-based. And there are three different types of personality disorder underneath. Number one is avoidant personality disorder, dependent personality disorder, and obsessive compulsive personality disorder, OCPD. Now, DSM also talks about a set of personality disorder that do not fall into any of the above three clusters, and we will classify them as other. And there are three different types. Number one is a personality changes due to another medical condition. And number two would be other specified personality disorder. And number three would be unspecified personality disorders. All right. Let's talk about them one at a time and take a look at this slide. Very, very important. My lecture will follow. We'll start with cluster A, and we'll start with a paranoid personality disorder. All right, so cluster A, which is odd and eccentric classification, there are three types. I said paranoid, schizoid, and schizotypal. And These individuals, they often appear odd or strange. That's what the eccentric come from, a strange behavior. They tend to remain isolated, so that's a common theme for these clients. They're isolated, they're not going to cooperate with you or with a family member, and they're not concerned about how others are going to perceive them, so they don't care. So keep those things in mind, and as a group, as a cluster, but we'll talk about them one at a time. All right. So the first one on the list is paranoid personality disorder. So take a look at this image. For every disorder, I'm going to give you an image to take a look at it. And also I'll give you a description of that personality, some keywords that will help you. So pay attention to the image and some keywords that will really help you to understand the disorder and answer the question that you will see on the exams. All right. So paranoid, look at the client, he's being paranoid, is a pattern of a distrust. They do not trust, and there's a suspicious activity going on, right? So they do not trust. They believe that others have some kind of a motive that is going to be harmful to them. And these individuals with the paranoid personality disorders are generally difficult to get along with and often have a problems with close relationships. So next time when we see a client that you feel like they're being difficult, always understand that there must be a reason behind their actions, behind their behavior. And our job is, of course, never to judge any patient, but to really understand where they're coming from and hopefully offer them some interventions. All right. So here's the DSM 5TR criteria for that. You have to have these essential features to meet the criteria. Need 4 or more of the following. There are 7 altogether, but the overall theme is going to be that they do not trust someone. They suspect without any reasons. They believe that others are harming them, deceiving them. Um, they're preoccupied with unjustified doubts about the loyalty or the trustworthiness of their friends or the family members. I remember taking care of somebody, in the nursing home. I believe she was in her mid 80s or so. She was meeting the criteria for this. Her husband, who was also in his early 90s or so, she would tell us that, oh, I'm sure the reason he admitted her in the nursing home because he's cheating on her. And of course we confirmed with the family. It is possible that a 90-year-old male would cheat on his wife, so you always want to double check that. But and that wasn't the case. The family member, I believe granddaughter, said, oh no, that's not the case. Grandpa can barely walk with a walker. And there was no history of cheating either. Anyways, the point I'm trying to make here is that these clients are not going to trust you as a healthcare providers. They're not going to trust the family members and so forth. So the degree of a paranoia, take a look at it. And it's easy to identify these patients when you um, when you take a look at the criteria. If criteria are met prior to the onset of schizophrenia, then make sure we add pre-morbid, because it is possible that um, later on the clients are diagnosed with schizophrenia. Okay, so for example, you'll say paranoid personality disorder pre-morbid, and then the primary will now be schizophrenia. Okay, what do we do with these clients? Well, the treatment approach for pretty much all of the personality disorder is going to be highly individualized. It's going to be multi-modality, format, if you will. We always start off with or try to start off with non-pharmacological intervention. So that would be psychotherapy, for example, CBT, cognitive behavioral techniques. We can always do group therapy. People learn from each other, right? That's always a good idea. And definitely there's a role of involving the entire family, or the family who are um, suffering from that behavior, if you will. So in that case, for example, spouse or parent. These disorders, being paranoid personality disorder, will cause some degree of anxiety. So anti-anxiety medications are given, plus minus antidepressant. So in other words, pretty much you will treat the underlying symptoms, or sometimes comorbidity that you have. If the client is uh, making some statements that appears to be, psychotic, then there's a role of antipsychotic medication, very low dose for a brief period of time. Remember, if you're treating schizophrenia, of course the doses are usually higher, and patient may take those medications for years and years. Um, but in these cases, doses are usually low dose for a brief period of time. So again, we treat the symptoms, underlying symptoms, or comorbidity. Now, those of you who were wondering that we have a paranoia in schizophrenia, that concept is there. But today we're talking about a paranoid personality disorder. So what's the difference? So these are similar words with different meanings. Um, Schizophrenia, when you have that paranoia component, these are individual. Of course, the similarity would be that both of them have a paranoia. They do not trust and suspiciousness, right? That's a similarity, right? Um, but the difference would be these clients who are suffering from schizophrenia, they are going to be relatively normal before the onset of the illness. So let's say the child or the client, let's say, is, I don't know, 21-year-old, and up to some degree, um, the client personality was kind of sort of normal before the onset of the presentation. Clients' beliefs are irrational and bizarre, but when the client is going through that psychotic phase, hallucinating, making delusional statements, is paranoia, um, their statements are irrational and bizarre, and hallucinations are generally present with paranoid schizophrenia. Now, on the other hand, the one that we are talking about today is a paranoid personality disorders. These clients, their behaviors can be often be traced to adolescence or even childhood, because remember, this is a personality that we are talking about. So it's not like all of a sudden one day you woke up with a paranoid type of paranoia feeling. So this was the personality, the trait that was developing, and we can trace that all the way to age 5, preschool, and so forth. Okay, these individuals, they overall they remain pretty much stable throughout their lifetime. You know how with these clients on the left hand side, a client who has schizophrenia, they are at risk of acute psychosis. They're going to the hospital and so forth. So their degree of uh, the burden of the disease, I can say, is significantly higher. They're at a higher risk. On the right hand side, these patients are usually stable throughout. I mean, when was the last time you really admitted somebody, or you saw somebody being admitted with a primary diagnosis of a paranoid personality disorder? It usually doesn't happen, right? You will have a client with something else being admitted. Maybe the client has a schizophrenia, or even maybe going through hip replacement. I think that's how I got my previous patient, the example that I was giving you, that 85-year-old female. She was there for recovering from some kind of medical issues, who happened to have a paranoid. So anyways, these clients' beliefs tend to be more unpleasant but not necessarily irrational or bizarre. So, for example, uh, this patient was telling me that the 85-year-old female example that I gave you, she said that I don't trust my family member. I believe someone is going to harm me, or I'm not going to eat because my husband is trying to kill me, or my husband is cheating. Now, someone is cheating or someone is going to kill me are not necessarily irrational or bizarre statements, because that is possible, right? These are unpleasant statements, but not necessarily irrational. On the other hand, during schizophrenia, these clients usually make bizarre or irrational statements such as, I'm talking to God, I'm having conversation, I can see God, or FBI is after me, or they're hearing voices, they're seeing people. Those are irrational statements most of the time, right? And another difference is hallucinations are generally not present with the paranoid personality disorder, whereas with the schizophrenia, hallucinations are usually present. So these are the differences. Take a look at it. A very important concept. All right. Now, second disorder under cluster A is schizoid personality disorder. So take a look at this image again, and this client is going to show you a pattern of detachment from social relationships and restricted in a range of emotional expression. So lonely, uh, detached from the society, and lack of emotions. So here is the DSM criteria. These are the essential features of schizoid personality disorder, that you have to have 4 or more of the following. There are 7 altogether. So take a look at it. They neither desire nor enjoys a close relationship, including being part of the family. They would rather be left alone. Almost always they choose solitary activities. They are not gonna, collaborate in a group setting or play with the groups. They have little, if any, interest in having sexual experience. Very important. They do not want to have a relationship. They are not interested in any sexual activities and so forth. They take pleasure in few, if any, activities. They do not have any close friends. They appears indifferent to the praise or criticism of others. So pretty much, no emotions. They show emotional coldness, detachment, and so forth. So take a look at it. The common theme is again social isolation and lack of emotion expressions. Make sure that these features do not occur exclusively during the course of a schizophrenia or a bipolar disorder and so forth. So if that is the case, then of course we need to call it bipolar or schizophrenia, right? If criteria are met prior to the onset of schizophrenia and pre-morbid, same thing that we talked about earlier. So example would be schizoid personality disorder pre-morbid. All right. Next is the treatment plan for these patients. Now, the treatment plan is going to be very similar to the one that we discussed earlier for paranoid. Again, start with the non-pharmacological interventions such as psychotherapy, CBT, group therapy, family therapy, anti-anxiety, plus minus antidepressant based on the need of the patients. All right. So number 3 is schizotypal personality disorders. So take a look at the image over here. So let me take a look at the definition here. It says a pattern of acute discomfort in close relationship, cognitive or perceptual distortion, and eccentricities of behavior. Now, these individuals, they are going to have uh, very similar personality as of previously discussed schizoid people that we just talked about. That is, they will have odd personality and lack of close personal relationship. However, The main difference here would be that in schizotypal individuals, they tend to have even more strange thoughts, very strange thought process, along with the paranoia. One main difference, if I can help you to understand this, would be that they tend to have a magical thinking that we didn't talk about in the first one or the second disorder that we did. So that's something different in this population. For example, these clients may tell you that that he or she is getting some messages from somebody. It seems like we have met before in a previous life. I'm actually taking care of somebody right now who makes these type of statements, and he always talk about that he know me from World War One or two, something like that. Very magical conversation every single time I see him. We really don't know the etiology for these, but as a healthcare provider, we always focus on the behavior, of course, not on the personality. So don't try to change their underlying personality, never argue with them. We just help them to focus and bring them to the reality, of course, right? All right. So here is the DSM-5 criteria for schizotypal personality disorder. You need 5 or more of the following. There are 9 altogether. Take a look at it. Here you have a client with ideas of references, odd belief or magical thinking that we were talking about. They believe in telepathy and sixth senses and so forth. Odd thinking and speech, suspiciousness, paranoid ideation, inappropriate or constricted affect. So you would know that when you're doing your mental status exam. And their behavior or the appearance is odd, eccentric. Well, we know that. Well, that's a theme, right? This is a cluster A, so that would be a theme for these disorders, anyways. And the lack of close friends and so forth. Anyways, take a look at it. I'm sure you're familiar with these verbiages now. So what is the treatment? Well, again, we want to focus on the behavior, not the personality. Focus on social communication skills by providing, socializing with others, with the peers, like a group therapy, family therapy, and so forth. Plus minus anti-anxiety if that's what they need. If you see features of depression, or if they are giving you features of psychosis, then we can always offer antipsychotic, treat the comorbid, treat the underlying symptoms. Okay, so that was cluster A. Now cluster B, the theme is dramatic and emotional. We have 4 disorders underneath. Number 1 is antisocial. We have a borderline disorder, personality disorder, histrionic personality disorder, and narcissistic personality disorders. So we'll start with antisocial first. All right, so antisocial personality disorder, which is a part of a cluster B, and take a look at the image over here. So you have somebody who is giving you a pattern of disregard for and violation of the rights of the others. There's some kind of a criminal history, impulsivity, and failure to learn from experience. So these are the keywords. Take a look at the image, and with that understanding, we'll talk about the criteria. All right. So here is the criteria for antisocial personality disorder. Um, it is not unusual to give a diagnosis of a personality disorder, any personality disorder, before the age of 18, with the exception of antisocial personality disorder. One of the essential features of this disorder is that the symptoms must begin in childhood or early adolescent, before the age of 15. They don't have to be diagnosed with conduct disorder, but the symptoms must begin at that time and continues into adulthood. And when we diagnose, the age of the client has to be at least 18. That is a very, very important concept. And the antisocial personality disorder looks very, very similar to the conduct disorder. Make sure you take a look at that lecture as well, and that is covered in a separate lecture, and you do have a link for that as well. So the point I'm trying to make here is that the age is very, very important for this diagnosis. Okay, so what are the criteria? Well, they need to meet 3 or more of the following. So 3 out of 7. So take a look at the first one: failure to conform to social norms with respect to lawful behavior, as indicated by repeatedly performing acts that are grounds for arrest. And second criteria is deceitfulness, as indicated by repeated lying and so forth. Okay. Impulsivity or failure to plan ahead, irritable behavior, aggressiveness, reckless disregard for safety of self or others. They're consistently irresponsible, as indicated by repeated failure to sustain consistent work behavior or honor financial obligations. Now, number 7 is also very important, that the clients have a lack of remorse, as indicated by being indifferent to or rationalizing having hurt, mistreated, or stolen from another. Make sure here this criteria is important. There's evidence of conduct disorder with the onset before age 15. Again, you just need an evidence, and make sure the occurrence of antisocial behavior is not exclusively during the course of schizophrenia or bipolar. So always take a look at the differentials. All right. Well, talking about the etiology behind APD, again, it's a multifactorial, reasons, but generally speaking, family history of adults with antisocial personality disorders shows there's a pattern of violence, neglect, frequent alcoholism, or they were being a victim of abuse. There is also genetic and environmental factors that can contribute to the risk factors of this disorder. Now, anti-social personality disorder is one of the conditions specifically studied by the epidemiologist, and they reported that more than half of the people with APD have a significant criminal history. The most common symptoms were that these individuals were having a difficulty to maintain their job. And even DSM talk about that these individuals, they may have a significant period of unemployment, despite that there was a job opportunities in the area or to them. So they were having difficulty to either keep that job or find a job. And also these clients, they had violence issue, traffic offenses, and severe marital difficulties. So that this tells you the overall burden of this disorder on a patient and on a society as a whole. All right. So you're looking at a study that was done. What they did was that they actually had a PET scan that was done on 41 murderers, and take a look at the normal PET scan, and more specifically take a look at the activity in the frontal lobe, and compare that activity to the PET scan of a murderer. What they found was that these individuals, they had decreased activity in the frontal lobe, And this frontal lobe is the area that is associated with impulse control and keeping, those aggressive behavior in check, right? In fact, violent repeat offenders had as much as 11% less frontal lobe tissue than the average brain. So it is possible that some antisocial personalities lack empathy because they simply don't or can't register others' feelings. And now I'm not trying to justify any behavior, but when you ask someone, what were you thinking? Why did you do that? The answer is that I don't know what they were thinking, but they were thinking at least 11% less than a normal individual would think. So something to take a look at. All right. Well, next, I just want to introduce a term or pretty much clarify something that students usually ask me this question: what's the difference between sociopath and a psychopath? Well, the term sociopath is pretty much, honestly, it's just a lay term that essentially means APD. That's all it is. We don't use that much. DSM-5 talked very briefly about that. It just introduced a term, if you will. But again, it's not necessarily a medical terminology, but it simply means antisocial personality disorder. That's all it is. All right, but psychopath, on the other hand, is a constellation of antisocial behavior and psychological symptoms. So it's a very complex. These individuals, they lack emotional connections with others and and an incapacity for guilt or remorse. Even though antisocial personality disorder talks about remorse, but these individuals, they are really, very complex, very far end of that spectrum, if you will. These individuals, they will remain calm during crime. They're not going to have any emotions. Um, in some studies, when evocative photographs like a child being hit or a woman with a knife at her throat, these photos were shown to psychopathic individuals, there was a little change in the heart rate and perspiration. So in other words, there was no changes in the vital signs as compared to the control group. They were very calm, did not make any changes to their behavior. Um, Psychopath, it indicates a malignant form of ASPD, antisocial personality disorder, and appears to fall at the severe end of the antisocial behavior spectrum. So most psychopaths meet the criteria for ASPD, but not all persons with ASPD are psychopathic. So that's a difference over there. The term is usually used in forensic setting, but not in a medical setting. So this is more of like I wouldn't even use this in a medical setting. I will simply call antisocial, but for lay terminology, this would be a clinical setting term, but this is more of a forensic setting. And these clients are far more complex. And if I can say that, they're far more dangerous as compared to ASPD clients. All right, so I think it's important. The reason I wanted to share that because it is important to know the difference so that we do not incorrectly define or make a label about our patients. And hopefully this slide will remind you how important it is to know the difference. It says, I'm not a psychopath. I am highly functioning sociopath. Do your research. So yes, I think it is our responsibility to know the difference. All right. So what is the treatment? Well, as we know that the treatment is highly individualized. We talk about importance of non-pharmacological interventions, give them options: psychotherapy, CBT, group therapy, family therapy, plus minus anti-anxiety, antidepressant, antipsychotic, and treat the comorbidity. Now, one thing I'll tell you is that with antisocial personality disorder, it is not uncommon for them to have a comorbidity of ADHD. And if that is the case, remember these individuals are very young, and it starts at age 15. Some of the symptoms, especially if they're meeting the criteria for conduct disorder, and we know that later on those symptoms will be used to diagnose a client with antisocial. So ADHD is a comorbidity with a conduct disorder and with antisocial disorder as well. So it's important to treat that as well. And I do have a few clients who have a diagnosis of antisocial personality disorder, and I am treating their ADHD as well. Now, next type of disorder is borderline personality disorder. This is also a very interesting disorder. So remember the common theme here is dramatic and emotional, right? So take a look at the image, and let's take a look at the definition here. So these clients with BPD, they're giving you a pattern of instability in interpersonal relationship, self-image, and affects, and marked impulsivity. So look at the left side, they're happy, sunshine, everything looks good, and now having a bad day, so there's instability. Also, these clients will show you mood swings during the interaction. So when you're going to interview the client, they may jump from laughing to tears within a second. So pretty much resembling that psychotic behavior, if you will. So take a look at the definition, take a look at the picture, and we'll talk more about this. So here's the DSM-5 TR criteria for that. So borderline personality disorder is typically an adult onset disorder. However, symptoms in adolescent as young as even 12 or 13 years can be present, and they can actually meet a full criteria for that disorder at that age. In general, symptoms tend to lessen in severity when the individual enters their 40s, and so however, you can have a relapse. Always take a look at the presentation, especially if the symptoms are presenting at early age. Take a look at a criteria for bipolar disorder. Okay, you need 5 or more of these, and so there are 9 altogether. You need a 5 out of 9. So these clients again are going to give you that issues with unstable self-image, impulsive behavior. The main thing you really have to worry about is the suicidal behavior. They're at a very, very high risk for that. So here's the mood changes and so forth. All right. So we talked briefly about the comorbidity with borderline personality disorder. It's very common to have other disorder that co-occur, and that would be either depressive or bipolar disorder, substance use, anxiety, particularly panic disorder or social anxiety disorder. You can also have a client with eating disorder, either bulimia nervosa or binge eating. PTSD is common with that. ADHD is also very frequently co-occur with these disorders. So very, very important to do a very good assessment and treat. You can only imagine, if we failed to diagnose someone with ADHD or PTSD, how are we going to offer a treatment for borderline? So correct diagnoses are very, very important. All right. Well, take a look at this slide. One authority states that the medical setting provides a fertile soil for borderline people to experience regressive emotional states. These individuals are unclear as to the source of the physical and emotional discomfort of their illness, tending to blame their pain on others. And that others is either family member or us as a healthcare providers. And they may react to painful interventions as specifically motivated hostile acts. Now, these clients are often very difficult, for us to manage. And we talk about this disorder as these individuals are very demanding and very emotional. These individuals are frequently annoyed and get angry at the healthcare providers, clinicians, nurses, doctors, and so forth. They have inappropriate anger or difficulty controlling anger, right? Because borderline personality disorder have a difficulty maintaining a healthy relationship with anyone, including healthcare providers and so forth. Unfortunately, they ended up getting fragmented care, and that's really sad. These patients are indeed very difficult patients. Similarly, they also find healthcare system very discriminatory as well. They believe that they're being discriminated, and this cycle actually continues. They blame the healthcare providers, and healthcare providers, some clinicians don't like to take care of them because they're very demanding. So the cycle unfortunately continues. I also want to add that these people do not use um, any like a lethal method to harm the providers or the family members. They may make statements, but they very rarely act on those. However, they are at higher risk of harming themselves, though. So that is very, very important for us to understand. Um, we as a healthcare providers, we should always maintain a therapeutic relationship with these patients, with any patient, but more specifically when you have a very challenging patient. We always want to be very firm, very consistent, and show empathy while we provide care. I'll give you share you an example. I took care of somebody who was, I believe, in her maybe early 50s or so, but she was also diabetic, and I was actually managing her diabetes at that time. And she had official diagnosis of a borderline personality disorder. And every time I would, and she was in a nursing home, and then I would adjust her insulin, and she was very, very thankful, very appreciative, and so forth. And and I said, I'm going to arrange your consultation with a dietitian because your blood sugars are very, very high, and then I want to discharge you, but I want to make sure that your blood sugars are controlled with the diet along with the insulin that I'm giving you before I discharge you. And she was very thankful for that. Anyways, I arranged that consultation, and a few days later, the dietitian told me that she goes, I just want to warn you that be careful. Your patient that you referred me the other day, she made a statement that she doesn't like me. She said that she has a plan to kill me and or harm me. And I go, really? I mean, she was very, thankful, and every time I go, she's very nice. But I knew that she actually had borderline personality disorder. So a couple of days later, she was actually walking in the hallway, and my office door was opened. I always leave my door open, but it's so she comes in, and she goes, you are the reason. She's pointing fingers at me. She goes, you are the reason why I'm still here, and for some odd reason you can't just manage my blood sugars. You don't know what you're doing. And then and then literally within few seconds, she goes, "Oh my gosh, I love your tie that you're wearing. That shirt looks good on you. That tie looks good, and thank you so much for everything that you do for me." And she was very, very thankful. And a couple of days later, or maybe weeks later, I actually had a student with me, and she did the same thing. You are the reason. She was blaming me, and then within the same sentence, she goes, "Oh, thank you so much for everything that you're doing for me." And student was very confused. So we had a wonderful conversation that day with the student that here's your a typical presentation of somebody with a borderline personality disorder. All right, so the moral of the story is we don't judge our patients. We treat everybody with respect, and we allow them to verbalize their feelings, and we go from there, right? So talking about a treatment, psychotherapy is the first line treatment for these individuals. However, it is very difficult for both the patient and the therapist, because these clients, they do act out their impulses and they regress very easily. Clients will show that splitting defense mechanism, right, that cause a client to alternate like and dislike the therapist. The example that I just gave you, at one point she likes me, and within a few seconds she dislikes me. So that split defense mechanism that they have makes these therapy sessions very, very challenging. But anyways, the treatment of choice for these individuals are DBT, dialectical behavioral therapy. That is most commonly used and heavily studied with very promising results. The goal of this treatment is to improve the interpersonal skills, and of course to decrease that self-destructive behavior that they use. One of the technique that we use in our facility, we have a very well established, very well written DBT program in my facility that I work at, and we use multiple strategies for these patients, such as storytelling, videotape, and playback those videotapes to allow them to self-reflect on how their actions will affect others, and of course themselves as well. And when we record those sessions, that will help them, that assist them in improving their interpersonal behavior. Of course, we can offer group therapy, family therapy as well, and medication treatment, offers plus minus anti-anxiety, antidepressant if mood is the problem. We can always do a mood stabilizer, such as like a Depakote or maybe lithium. And of course, low dose of neuroleptic, which is your antipsychotic medication, can also be used in these patients. Now, in rare cases, we can actually admit these patients. We can hospitalize up to 1 year when a home environment is not safe for these patients to get rehab. And then that unsafe environment comes from the fact that you may have a family member that these individuals have a direct conflict with, or maybe they're living with a significant other or a family member in a very abusive relationship. So it is much easier to hospitalize in that setting at that time. And then of course later on we will transfer them to either day care, day hospital, night hospitals, or halfway houses. We do have those options. All right. Well, next type of disorder under cluster B, we're still under cluster B, this is number 3, is histrionic personality disorder. So take a look at these two images, and let me show you the definition. So it's a pattern of excessive emotionality and attention-seeking behavior. So these individuals are going to seek attention. through either dramatic or exaggerated expression of emotions. So they're very, very dramatic. That is the theme for cluster B anyways, right? So these individuals are very shallow and attention seekers. They crave being the center of attention, and they will dress in a way that call attention to themselves. Um, Although there's clearly some similarities between the borderline and histrionic personality. For example, both of them can have mood swings. So they will laugh and laughing to tears, in one sitting. But borderline personality disorder, they tend to shift emotions to blame others. However, in histrionic personality disorder, that is not the case, because they keep their primary aim is to keep themselves as a focus of the attention. Now, these individuals, they may use physical appearance or provocative behavior to draw attention. It is common to have both traits. Um, these individuals, they create a scene to get attention. They know that they may make up stories to get that attention. Now, in the clinical settings, this disorder has been diagnosed more frequently in females, and that's why I have this image. However, please remember that we do have, a few studies that report similar prevalences rate among males as well, males and female. So take a look at this. With that understanding, let's talk about the DSM-5 criteria. So for us as a healthcare providers, we need to remember that these clients will provide a very dramatic description of physical or psychological symptoms. In every single time we see them, it seems like story is changing. They replace new symptoms each visit. They, according to DSM-5-TR, they have to have a 5 or more of the following. There are 8 altogether. And take a look at it. You have a client who's uncomfortable in a situation in which he or she is not the center of attention, interact with others, and is often characterized by inappropriate sexual, seductive, or provocative behavior, and so forth. So I do have a patient right now that I'm treating. Every time I see her, she describes her symptoms each visit, in very differently. And before she start explaining her symptoms, she'll say, "Oh, I know you're not gonna believe me, but I had a rash the other day, and that rash was very, very big, very red, very hot." And of course, I don't see anything, so I confirm with the nurse, and the nurse will say that no, that's not the case. That there's nothing wrong. She's fine. There was no rash, anything like that. So, but you always want to make sure that you confirm. You do the assessment. I always take any time when my patient make any type of statement. Of course, we always want to address that, or at least investigate, because you never know if this time they might be sharing something genuine. They may have a correct symptom that they're reporting, right? So always take these individual seriously, but always keep that diagnosis in mind as well. So don't do unnecessary testing either. So I wouldn't prescribe any antibiotic or any ointment for that patient, right? All right. Well, as far as a comorbidity is concerned, I think I mentioned earlier that sometimes it is very difficult to distinguish between histrionic personality disorder and borderline personality disorder. But generally speaking, borderline clients with the borderline disorder, suicide attempts and psychotic episodes are far more likely to occur than individuals with histrionic disorders. Now, I'm not saying that the clients with the histrionic personality disorder are not at risk for suicidal ideations. Of course, they are. But it's a far more likely to occur in borderline cases. And you can have both of these disorders together, right? That's a comorbidity. You can have borderline as a comorbidity, narcissistic, paranoid, dependent, antisocial personality disorders, alcohol and some other substance use, and even somatic symptoms. Functional neurological symptoms, we used to call those convergent disorder, and some major depression disorders. So there are a big old list of a comorbidity that these clients can have. All right. So what is the treatment plan for these? Just like everything else, we'll start off with non-pharmacological interventions, psychotherapy, and more specifically, psychoanalytic therapy. They need to analyze their behavior. We can offer group therapy, family therapy, plus minus anti-anxiety, antidepressant, and if needed to treat some psychotic features, we can do antipsychotic, a very low dose for short time frame. Always want to treat the underlying symptoms. All right. Well, next type of a personality disorder under cluster B is number 4, which is narcissistic personality disorder. Take a look at the image here. The first image here, you have a client standing in front of the mirror, and see how he perceives himself or herself. And here you have an image of what he is thinking, me, myself, and I. There's no collaboration here at all. And the definition here is that you have an individual that shows a pattern of grandiosity. And these individuals, they need for admiration and lack of empathy. These individuals are self-centered, inflated self-esteem. They always overestimate their ability. They truly feel they are superior to others, and they have lack of empathy. They believe they're special, they're unique, they have a high status, some degree of or high degree of sense of entitlement, show arrogance. Now, unlike a borderline personality disorder, where you can have individual who are susceptible to psychotic episodes, narcissistic persons, they do not show these symptoms. So they are not, when they are saying that they are superior, they are better, they are not psychotic at that time. They're alert, very alert. They're making those statements because they truly believe in that, and that's not a part of hallucination. Under stress, however, these individuals may experience some anxiety and so forth, especially if they all of a sudden, if they lose that power, if they get fired, they were let go. So they can go through that anxiety and oppression. Overall, narcissistic personality disorder, the prevalence is about 1.6% or so. Okay, so let's talk about the criteria in a minute. All right, so here's the DSM-5-TR criteria. You need 5 or more of these elements, features. The first one on the list is these individuals, they have a grandiose sense of self-importance. They talk about their achievements, their talent, and how they're superior. They're preoccupied with the fantasies, unlimited success that they have, the power that they have, beauty, the ideal love. They talk about that as well. Believes that they are special, unique, high status people. Sense of entitlement, we talked about that earlier. Lack empathy. One thing that I'll just want to highlight here is interesting fact, may not surprise you at all, but when we talk about adults age 18 and older, adults who are diagnosed with narcissistic personality disorder, more than 50, about 75% of these individuals are actually men. So these gender differences suggest how men react in response to stress as compared to women who are generally more empathetic. So something to take a look at when we compare these disorders. We also notice that some disorders are more common in women. Um, you know, like a dependent disorder. We'll talk about that in a minute. But this one is more common in men. So what is the treatment? Well, first of all, it's very difficult to actually offer treatment, because remember earlier we talked about the fact that most of these individuals, they do not believe that something is wrong with them, right? Because these symptoms are not bothering them. Um, we talked earlier about egocentric concept behavior, right? So it's very challenging, but once you have officially diagnosed and then the patient is willing to go through a treatment, psychoanalytic approach is used so that we can teach them to learn how to share with others and develop that empathetic response to others. um, we can always offer group therapy. That's how they will learn how their behaviors are impacting others. And of course, family need a treatment as well. um, when we offer these treatments, when they're in the real world, when they're implementing these new changes that they're learning, that may cause some anxiety because they're not used to dealing with the world that way. So plus minus anti-anxiety at that time, antidepressant medication, um, and when the mood is when they're going through those mood swings, lithium seems to be very effective in these individuals. um, Rule of thumb is do not feed the behavior here, right? Focus on that reinforcement. Let's talk about this one more time and offer those healthy coping skills strategies to these individuals. And of course, if they are giving you the features of psychosis, then plus minus a low dose of antipsychotic medications. All right. Well, our next stop is cluster C, and the common theme for cluster C is anxiety and fear-based disorders. Take a look at this image and see how very well this is organized. And if you move any of these items out of the order, that's going to cause a lot of anxiety for some people. So keep that in mind. And there are 3 disorders that will fall under cluster C with a common theme of anxiety. The first one is avoidant personality disorder. Number 2 is dependent personality disorder. And number 3 is obsessive compulsive personality disorder, OCPD. All right. Well, our first disorder under cluster C is avoidant personality disorder. Take a look at this image over here. You have a client who's trying to hide, who's trying to avoid encounter with someone else, with external world, if you will. So you have a pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation. People with a cluster C, they appear to be very anxious. And remember, that was a common theme for this cluster: anxiety, anxious. These individuals are going to avoid any interaction with someone that may result with rejection. They are going to be very shy. People describe them as invisible. It's one of those people that you come across, you say, well, I never knew that you work here. I have never seen you before. They don't eat in the break room, or they don't visit. Some students, if they have this personality, if I tell them good job, they're gonna like that compliment, but they're gonna spend too much time and energy in worrying about the fact that what if I tell them tomorrow that they're not good. They're very hypersensitive to those remarks. You have to be very, very careful with these individuals. All right. So here's the DSM-5 TR criteria. You need 4 or more of the following. There's 7 altogether. One thing I want to highlight here is that the avoidant behavior often start in infancy or early childhood. During the chart reviews or when we interview the family members and friends and so forth, they will describe these individuals as being very shy and isolated behavior. They had a fear of strangers or being in a new situations. Also, FYI, these disorders are, or this disorder is more common in women than in men. One point here I want to make here is for number 3, decrease interest in or desire intimacy. They It's not that they don't want to be in a relationship, they do, but they don't because they are worried. They are fear that there's a fear that they may be later rejected. So they prefer to be alone. Now, there's a difference between avoidant personality disorder and the one that we discussed earlier, schizoid personality. Remember, those individuals, they do not have any desire for any sexual relationship. They truly prefer to be alone because they don't want. These individuals, they would like to have a relationship, but they don't because they're worried about a rejection. So that is the difference. All right, some researchers suggest that the etiology is that individuals, they have a history of being in a family where the opinions of others were held in very high importance, and the opinion of the child was was not regarded, was not noticed. So it's very, very important to really involve children with the decision-making process, give them option, let them know that they're important, as simple as what would you like to eat today, where would you like to go during summer break, give them a few options, what movie would you like to watch. That way they understand that their opinion matters and they do not grow up with this avoidant personality. That's one theory. Because otherwise what happen is, if you don't involve them, the child is socialized to believe that public exposure can result in humiliation. All right. So the treatment approach for these individuals should focus on encouraging them to move out into the world, to take what is perceived as a great risk for failure, rejection, and face that and talk about it during CBT, during group therapy, so that you can share and learn from each other, plus minus family therapy, if needed, anti-anxiety, because you remember the main issue is anxiety here. It's going to cause some anxiety, especially when they're being exposed to the outside environment. Beta adrenergic receptor antagonist, these are your beta blockers, such as propranolol, atenolol, can be given to manage that autonomic nervous system hyperactivity. I actually prescribe propranolol a lot in my patients to calm them down and minimize their anxiety. Antidepressant can be given, plus minus. All right. So second disorder under cluster C is a dependent personality disorder. And remember, cluster C, the theme is still anxiety, right? Anxiety and fear-based. So take a look at this image. You have an individual who's having difficulty here. He's begging her to stay. And the definition here is you have a pattern of submissive and clinging behavior related to an excessive need to be taken care of. So the client with the dependent personality disorder, they have a need to be taken care of by others. So they're very submissive, self-sacrificing, needy behavior. They cannot make simple decisions, and they cannot express disagreements. They're willing to do whatever others want. Now, I do want to make a point here is that even though in the image I have a male individual in the picture, but this is diagnosed more frequently in women as compared to men. Remember, the narcissistic personality disorder was diagnosed more common in men than women. So these are the differences. Okay. DSM-5 TR talk about this as having 5 out of these 8 criteria. So we talked about that. You have a client who's having difficulty making everyday decisions, need others to take that responsibility, and so forth. Take a look at it. We already covered this. Okay, some researchers they suggest that the etiology is that these individuals, they have a history of that during early childhood, parents did everything for these children, and they did not stop. The parents did not stop nurturing the child, so the child become incompetent and begins to believe that he or she cannot do anything. Um, you know, that's just one theory, by the way. There's so many factors, of course. So the only option for that child was to be submissive. All right. So if you have a client who's a dependent, and especially if that client is in abusive relationship, we should intervene. We start with the psychotherapy, and then we give them that insight-oriented therapy. We talk about behavioral therapy. Group therapy is also important so that they can learn from each other. But when we offer, when we notice that abusive relationship that the client is living in, we offer options to seek out help from other family members or even from the police. But if the client is not ready to show to get that help, make sure we acknowledge that and we respect that. We need to respect their feelings of attachment with that person, even if you know that there's an abusive relationship, because these are adults. But remember, they have to be adult, right? Because they can take care up to some degree. They do have a right? So if it's a minor, of course we have to intervene. If it's elderly, I get that. Adult patient, we have to respect that, even if you as a clinician disagree with their choice that they're making. Remember, the whole idea about a therapy session is not what you would do, right? It's all about what our clients are willing to do. Are they ready to do that at this time? So we just keep offering options. Of course, offer family therapy. Now, set limits regarding what we as a clinician, what we can do for these clients and what is expected from them. Remember, they're dependent, so you do not want these clients to be dependent on you. That would be a horrible therapy session when the client is dependent on a therapist. A therapist should be able to take time off, and an individual should be able to handle those stressful episodes with the coping skills that they have learned over the weeks. All right, so it would be a problem if you told your client that you're taking, let's say, 3 weeks off or something like that, and now they're having anxiety. That means your client is dependent on you. That's not a good thing. And even at the hospital, when you have a client, let's say the client is admitted and the client asks you, can you do this for me? I'll give you a basic example. If the client asks you to, can you wipe my bottom, let's say, well, as long as they're not paraplegic, make sure you rule that out. You let them know, no, I'm not going to do that. I want you to do that. You want to keep using your muscles and so forth. So of course we have to be very careful, very respectful, but set boundaries, set a limit. Okay, anti-anxiety, when they go through that anxiety episodes, antidepressant, SSRI, you can do SSRI, but TCAs also have a benefit here, especially when you have a client who have high levels of separation anxiety or panic attack. That seems to be very effective. All right. Number 3 under cluster C is OCPD, and that is obsessive compulsive personality disorder. So take a look at this image. I am not a control freak. I just like things my way. So take a look at the definition over here, or the description. A pattern of preoccupation with orderliness, perfectionism, and control. So according to DSM-5-TR, these individuals are preoccupied with details, list, rules, schedules, and so forth. You need 4 out of 8. So these are the client, they always want to be perfect, and unfortunately there's no such thing called being perfect, right? You cannot really achieve that. But these individuals, they're excessively devoted to work and productivity. They really cannot delegate these tasks because they truly believe that no one can do a better job than them. And that might be a true statement, that's possible, but at the end of the day, that's not healthy. So anyways, take a look at that, and their behaviors become very rigid. They cannot really change their habits. Okay, so that's that. Some researchers, they suggest that the etiology is that these individuals, they may have a history of getting little warmth in their childhood homes. Praises was rarely received, and describe frequent punishment or very tight discipline for failure to be perfect. In large population-based studies, OCPD personality disorder appears to be equally prevalent in both men and women. So see how in some disorders were more prevalent in women, like dependent disorder. Some were more prevalent in men, like narcissistic personality disorder, and OCPD has equal prevalence rate in both men and women. All right. So what are the comorbidities for OCPD? Well, individual with anxiety disorder, for example, either generalized anxiety disorder, separation anxiety, social anxiety, or even phobia, they're at increased risk or risk factor, you can say, or they can have this as a comorbidity. You can also have, how with the type A personality, traits that we see, that can be a comorbidity, which is very common in healthcare professionals. These individuals are actually at high risk for MI, and that could be because of underlying stress, anxiety. So not a good thing. At high risk for depression, bipolar disorders, and eating disorders. All right. Well, as far as the treatment is concerned, unlike other personality disorders, these clients, they're actually aware of their symptoms, and therefore they will seek treatment. Remember, we talked about the concept of ego dystonic behavior. So these individuals are aware of their symptoms, and therefore that's a good thing. They will ask for treatment. So we start off with psychotherapy, non-pharmacological interventions such as CBT, group therapy, plus minus family therapy. And as a clinicians, we should always recognize that these rules and then orders are very important to these patients, these clients. So when the client behavior causes a personal difficulties, assist them to adapt by allowing them to arrange aspects of their environment. So we see that in the hospital setting, when all of a sudden their environment is changed, they like to have a remote control on the right hand side, and maybe water pitcher on the left hand side, and pillow, needed two pillows, whatever the case is, shoes has to be on the right, and that can cause anxiety. So we have to understand that, we have to respect that. um, Plus minus, we can offer anti-anxiety medication, benzodiazepine, antidepressant, SSRI, fluoxetine, anywhere from 60 to 80 milligram per day. It's very effective. I do have a lot of patients who are on fluoxetine for these reasons, and it appears to be more effective than some other antidepressant. And of course, if for whatever reason a patient cannot take SSRI, TCAs are available. I actually, at this time, I just have a one patient who wanted to be on this, and that's at one point I think I had her for SSRI, and then we discontinued, and then there's a breakthrough symptoms, and I'm treating her with TCA right now. All right. Well, those of you who are wondering what's the difference between OCD and OCPD, so here's your answer. Well, both OCD and OCPD, there's some similarities. Both individuals will have that rigid behavior. You can't change that. But the differences are, with OCD, psychological normal accept a situation that evoke their obsession and compulsion. They're able to hide their symptoms very successfully from their friends. The example under OCD is when you have an individual with the symptoms that involve a fear of contamination, may be very uncomfortable of food is placed back on the table after having fallen on the floor. This person may not care in the least if the candles are knocked off the table or chairs are arranged differently, because the fear is one object specific. It's a food. So this individual with OCD, if their issue is a food contamination, they're only worried about food here. So they would care less if chairs are arranged differently or not. On the other hand, with OCPD, these individuals may be uncomfortable if papers, books, or furniture are moved in any way. So they're very, very rigid. Soup must never be eaten before salad. Dessert never be eaten before meal. Television must never be turned on before windows are opened, and so forth. The rigidity in OCPD is a very extreme and applies to virtually all aspects of life and behaviors, because we are talking about a personality. This is a personality. So personality is applied all over the entire lifespan, in all aspects. Unlike OCD, where that rigidity is fear specific, usually one thing, could be multiple, by the way. You can have a multiple portion, but rule of thumb is OCPD is far more advanced, if you will, and it actually impact the individual at a larger scale. All right. So those were the clusters. We did ABC clusters. This is not a cluster. This is just hanging there, in like a miscellaneous column, if you will. We call that other. Take a look at the picture. So somebody's standing out. Other. So there are three disorders that will fall under other. The first one is personality change due to another medical condition. So this time you're going to have some medical reasons that will change the personality. And then number two is other specified, and number three would be unspecified. Some personalities just do not fit in any of the personalities that we discussed earlier. So therefore they reserve they were reserved under this special other category. All right. Also, I want to make a note here that we used to have a passive aggressive personality disorder, and that category has been removed. It is not a part of a DSM-5 TR anymore. It's not official diagnosis. All right. So here's the DSM criteria for personality changes due to another medical condition. That's number one here. And remember, you're looking for a medical reason, not a mental disorder, right? So you have to have evidence, either H&P, physical exam, lab findings, and so forth. So look for either CT scan, MRI, anything that can explain. The examples would be maybe they had CVA, stroke, and that the personality changes all of a sudden, right? Maybe dementia, HIV, hypothyroidism, um, anything that can, maybe infection, maybe sepsis, maybe seizures, Huntington disease, anything that can change the personality will fall under. And this time we'll rule out, make sure these behaviors or the personality is not explained by any type of mental disorder, so you rule that out as well. And then we specify if it's a aggressive type and a paranoid type and so forth. All right. And then we have number two as other specified personality disorder. So this is used when you have a client who comes in with the symptoms presentation, but they are not meeting the full criteria for any of the disorder that we have discussed so far. But we do have a specific a reason, I guess we can say, any situation where we will specify that this personality is due to blank, whatever that case is. For example, mixed personality features. And then the last one, number three, is when you have a client with unspecified reason. The patient is coming in with all the presentation, but they're not meeting the full criteria for any of the disorders. We cannot specify, we don't have enough information, and we are going to decide not to specify at this time, so that would be unspecified. And again, usually done in emergency situations, and every attempt should be made later on to reassess and make a specific diagnosis. All right. All right. So in summary, I just want to highlight that the first step should be that we as a healthcare providers, we should evaluate our own feelings in reaction to the personality disorder. Many mental health professionals are reluctant to discuss the diagnosis of personality disorder. But we should have a frank discussion, open discussion with our clients. We need to discuss the treatment option with them, involve them to develop that collaborative care plan. And always remember that in order to really diagnose someone, there has to be some degree of impact on their ADLs or social life and so forth. And the anticipated outcome should be to reduce the inflexibility of a personality trait that interfere with the functioning and relationship. It's a really ongoing process. You give them some tools that they can apply to really minimize that pain and suffering they're having from those personality disorders. Or sometimes it's the family members, significant other, or parents who are suffering, or friends, loved ones. All right, so I just created this nice table for you. On the left hand side, this is going to give you a good summary. You have a cluster A, B, C, and then I gave you that basic description. Here I listed all the disorders that fall under cluster A, fall under cluster B and C, and then I gave you basic definition. This is a very good recap. I literally created like a nice cheat sheet for you. Hopefully this will help. All right, with that, we have completed the lecture, and let's see if you were paying attention or not. So what I have next is a very fun activity, a discussion board scenario for you. So let me give you the instructions. Before I do that, I do have a disclaimer, as a statement that I want to make, that this activity is a work of fiction. This is for educational purposes only. Under no circumstances I will ever discriminate anybody based on their either medical or psychiatric conditions. And please understand that this is just a fun activity, if you will, to just summarize our understanding of these disorders. Okay, now with that, let me give you a situation. So let's imagine you are a manager or a supervisor at a local hospital or a clinic. It doesn't really matter. So some kind of a healthcare facility, and you are going to hire another professional. You are planning to hire either a nurse or a provider. Doesn't really matter, to be honest with you. I'm going to let you decide who, the position. It's not that important. Anyways, what's important is that accidentally you came across their medical file and you found out that they have one of these personality disorders that we just discussed earlier, right? So okay, let me back up for a second. In real life, should that happen, the best approach is to remove yourself from that situation. Just let somebody know that, hey, I accidentally opened that file and now I know their medical or psychiatric history, and therefore I cannot be part of that committee. Okay, so that's a right way of handling it. However, for the purpose of this activity, let's say that that's not what you did. You actually decided to create a list of applicants that you believe are going to be a potential good fit for your organization, and the second column would be the one that's not. So what I'm going to have you do is you create two columns. Column A is going to be less likely to offer a job. These are the applicants based on their disorders, personality disorder. You're not going to hire them because you believe they will not be able to do the job. And then remember, you get to create the job description, whatever. I'm going to let you decide that. Be creative and don't spend too much time, by the way. All you have to do is really look at the type of personality disorders and decide whether or not this person will fit in your department or not. Okay, so column A, you're not going to hire, less likely, and column B is most likely they're going to be good candidate, and then you most likely will hire them. So this is pretty much what I want. I want you to create two columns, and on the left hand side you have a type of disorders that you believe are not going to be good fit, and on the right hand side they're going to be good candidates. So for example, I don't know, let's say antisocial personality disorder. So is that person going to be on the left side of this table or the right? And OCPD, is it on the left side or the right side? And that's all you're doing. You're just listing the type of disorders, and very briefly in parentheses you're going to give me a description why you believe those candidates were a good fit or not a good fit. Very like one sentence, very, very brief. Okay, that's all it is. And once you do that, make sure you upload and under assignments, and I will give you the answers later on. And that's all I have. As usual, please feel free to contact me if you have any follow-up questions. Thank you so much for your time.